Hi, this is Dr. Purcell. Let's talk briefly about anti-inflammatory drugs, ibuprofen and ketorolac. Just a reminder, the concept we're covering here is inflammation, even though we will probably look at these drugs again when we do the concept of pain. A quick reminder that inflammation is a localized protective response stimulated by injury to tissues. Now, with autoimmune disease, your inflammatory response can be systemic, actually. But for the most part, you cut yourself or you stub your toe or you do something like that, and you have the response to that is inflammation. And part of that is pain. Clinically, what do you see when there's inflammation? You see pain, fever, loss of function, redness, and swelling. So let's look at these non-steroidal anti-inflammatory drugs. We also call them NSAIDs. It's a very large group of drugs, as you will see when we list them all here in just a moment. But it's large and chemically diverse. So not every NSAID is used for the same purpose. They all have analgesic, anti-inflammatory, antipyretic, and aspirin platelet inhibition properties. They're also used for the relief of like mild to moderate headaches, just general myalgia, such that happens when you have like the flu or a virus, neuralgia, arthralgia, alleviation of post-operative pain. NSAIDs are very, very effective in this area. Because when you have post-operative pain, as healing occurs, as it's supposed to after surgery, the pain diminishes as the healing increases. And that is why NSAIDs are so effective here. It's also used with arthritic disorders and treatment of gout and hyperuricemia. As I mentioned, all of the NSAIDs share the common properties of being antipyretic, analgesic, and anti-inflammatory. We have salicylates, which we will discuss at another time in this course when we look at aspirin for use as an antipyretic, and there's several others listed here. We have acetic acid derivatives, and now you can start to appreciate just how broad this category of drugs really is. Under the acetic acid derivatives, we'll have ketorolac, and then there are propionic acid derivatives, and we will look at ibuprofen here. So what is the mechanism of action? And you may want to revisit your pathophysiology textbook and find a visual aid that shows the whole inflammatory response. And if you do that and you plug in where all these drugs we've studied for inflammation, where they work in that cascade, that may be a visual help to you. But basically, they inhibit the leukotriene pathway and the prostaglandin pathway, either one of those or both, depending on which type of NSAID, which one they are. Overall, they block the chemical activity of the enzyme COX. And there are COX-2 drugs as well, we're not covering in this discussion. But I want you to remember that they will block the activity of the enzyme COX-1 and 2, but the COX-1 enzyme has a role in maintaining the gastrointestinal mucosa. So if we're blocking that, now we have a problem that can occur with gastrointestinal mucosa. And when we talk about the adverse effects of the NSAIDs, this is going to be a big deal, and then you can trace it back to the mechanism of action and how it works there. So what are the contraindications? It's this big, wide variety of drugs, and when you look at the list, many are available over the counter. But why would we not give an NSAID? Well, a known drug allergy always prevents us from giving something, or we give it with great caution. Somebody with a documented aspirin allergy should not receive NSAIDs. In my 30-plus year career, I think I've encountered one person with a documented aspirin allergy. And they had other things as well that were part of that whole process. But this is not very common. And then we worry more about the contraindications related to bleeding. Now, bleeding may not seem like a big deal because if you see the bleeding, you can put pressure on it, right? You identify it right away, people notice bleeding, and they put pressure on it to stop the bleeding. The bleeding we're more concerned about here is internal. The type of bleeding we cannot see, and that by the time it manifests itself, the clinical symptoms, the person, the individual has lost a great deal of blood and is actually in a very precarious situation. So if you have somebody who has peptic ulcer disease or a vitamin K deficiency, you need to understand that they're at higher risk for bleeding when we give NSAIDs, specifically in the GI tract because of the inhibition of the COX-1 pathway. Other adverse effects is also, again, related to GI. Some people have heartburn, from just basic heartburn all the way up to severe bleeding. Some have acute kidney injury, which we typically see with chronic long-term use of NSAIDs at high doses. Altered hemostasis, which we just talked about, usually that's going to be with our aspirin product, hepatotoxicity, and tinnitus, and that's with our aspirin too. To focus on the adverse effects for our two drugs here, our biggest ones are going to have to do with the gastrointestinal tract and the risk of bleeding. So what kinds of interactions can occur? Well, there are serious interactions, and number one at the top of the list is anticoagulants. So if somebody already is anticoagulated, and then we give them an NSAID that could cause bleeding, that's a problem. Aspirin and an NSAID both are blocking that COX-1, and you have a higher risk for a GI bleed. Corticosteroids, same thing. It's the exact same problem that we have if we're giving it with aspirin. And the others here are also interactions. The top three are the ones we're going to focus on. So why does renal function get affected? Well, if you go back to your pathophys, prostaglandins help to cause vasodilation in the renal arteries to allow blood flow to the kidneys. And NSAIDs block the action of prostaglandins. And so again, if someone's chronically taking NSAIDs, they are chronically causing vasoconstriction of the renal artery, which is reducing the blood flow, which then leads to internal damage within the nephron. So that's where we get the problem. It's not because somebody took it one time for a headache. It's the chronic long-term use. There is a black box warning on every NSAID because of the COX-2 drugs, and some of those have been pulled off the market. This was 10 or 15 years ago, maybe more, that had to do with the risk for adverse cardiovascular thrombotic events, including fatal MI and stroke. So we don't really see this happening with over-the-counter use of ibuprofen. It can happen with prolonged use of ketorolac, but they will carry the black box warning. So let's talk about ketorolac. It's an acetic acid derivative. The other name for it is Toradol, or in the sports world, it's commonly called vitamin K. Sometimes it's a little slang term for it. Now, you may wonder why we're talking about ketorolac when the book mentions that it only has some anti-inflammatory activity. Well, the reason it's here is because the way that it works with its powerful analgesic effects is its anti-inflammatory activity. That's why we use it when somebody has pain related to inflammation, such as post-operative pain, and it's an inflammatory response at the surgical site. And this is a very powerful pain reliever. And it actually has the analgesic effects of similar to morphine, but without having the opioid. It can be administered orally or by IM injection, and it's only available by prescription. It cannot be purchased over the counter. I don't think it ever will be. It is limited, if you're giving this in a post-op setting, for instance, or in the hospital, to a 5-day course. Anything beyond 5 days puts the patient at very high risk for renal damage and GI damage as well, that gastrointestinal mucosa and the breakdown and the potential for a GI bleed. So it is limited to that. So I have a question for you to think about. I'm not going to give you the answer. If you know it right away, that's great. Otherwise, it'll prompt you to look into your material and find the answer. So a hospitalized patient has an order for ketorolac. The nurse notes that the order is only for 5 days. And what is the rationale for this? Just talked about it, so you probably know the answer. But this is the type of question you can anticipate seeing on an exam. It won't be a question that says how many days is ketorolac limited to. You pick from 3, 4, 5, or 6. That's not the type of question. The type of question will be, you see that it's limited. Why is it limited? So that you have to really understand the whole meaning behind that. Moving on to our propionic acid derivatives, that's our ibuprofen. It's also known as Motrin or Advil, and I think there's another name for it too, another brand out there. But those are the two big trade names. Ibuprofen is the most commonly used NSAID in the world, and it's very safe, has a very favorable safety profile, which is why it's over the counter. It is, allowed over the counter. But its use is for the analgesic effects in the management of, and I'm going to read these things, and I want you to realize they all are related to inflammation. RA, which is rheumatoid arthritis, osteoarthritis, primary dysmenorrhea, which is cramps, menstrual cramps, gout, dental pain, and it goes on. So it is very effective at relieving inflammation, which is the source of pain most often. Over the counter, the formulations that you find are all 200 milligram tablets. And the instructions will say usually take 1 to 2 tablets, so they can take about 400 milligrams at a time, every 6 to 8 hours. Well, there's actually, when it was a prescription, the prescription amount was 400, 600, and 800. Or it might have just been 600 and 800. I do remember that, though, before it came over the counter. And if the 800 milligram tablet is still available by prescription, and it has an enteric coating, which helps to protect the GI tract so that it has to get into the small intestine before it begins to be broken down and absorbed. And we use that because of some people, especially with the arthritis pain, that need the higher dose, the 600 or 800 milligrams. And if you take the over-the-counter, it's not enteric coated. So if you take 800 milligrams, that means you're going to take 4 of those tablets. They're 200 milligrams each. And that is very dangerous on the GI tract. And people of any age can actually have a serious GI bleed, could be fatal, when they take that much ibuprofen in the over-the-counter form. So we need to make sure when we talk to our patients about their over-the-counter medication use, okay, you take ibuprofen, how much do you take at a time? And why do you take it? And how long, how many days do you take it? Not in a long time. Because we may need to talk to the provider about giving them the enteric coated tablet as to prevent the GI bleed. Now, understand that with ibuprofen, the real full anti-inflammatory effects take several days to occur. So that it is good for our, once they start to occur, it's very powerful. But our chronic use is acceptable. And people who have osteoarthritis and rheumatoid arthritis will use their ibuprofen every day. And that is the expectation, that they should do that because it allows them to keep their inflammation under control. Once it reaches a certain point, it's able to control that, and then they have quality of life. They can move, they can be free of pain or have reduced pain because they are controlling the inflammation. But these are the patients we worry about for the GI bleed, and we want to make sure they're not taking aspirin concurrently, and we want to make sure they're reporting any symptoms of GI bleed, etc. The maximum daily dose, now you may have heard that with acetaminophen, Tylenol before, but we also have it with ibuprofen, and it is at 2,400 milligrams in a 24-hour period. And so that 800 milligram tablet, you would take it every 8 hours. and that would give you your 2,400 milligrams. So for the nurse, if you are administering ketorolac or ibuprofen in a hospital setting, or a setting where the ketorolac, because it is by prescription only, you want to assess for conditions that would be contraindications. And think about that right now. It's anything that means that they can bleed easily, a bleeding disorder, or the fact that they're on an anticoagulant, or they already have active peptic ulcer disease. And so that leads you into conditions that require cautious use. Somebody who might be an alcoholic and have chronic gastritis, or think about other conditions that someone could have that would make us want to be very cautious. Maybe they have chronic kidney disease, and reducing arterial blood flow to the kidneys is maybe not the best idea. And then, as indicated, we would want to perform laboratory studies to see if it is safe to give this or not. That would only happen in a supervised setting. I can't point you in the direction of any labs that we would need to check before giving ketorolac or ibuprofen on a regular basis. So we always want to perform a medication history to assess for potential drug interactions and look for serious drug interactions and whether or not they exist. But I want to remind you that this is going to be the same information. These two pieces are there for every drug when you go, that you need to learn to assess for these. But remember, one of our two drugs, ibuprofen, is over the counter and has the ability for people to self-administer and self-medicate without anybody assessing any of this information. That is why it's so important when there is an encounter with a nurse or a provider that we always ask about the over-the-counter medication use so that we can then provide them with the vital information and safety information regarding taking that drug. Here's another question for you. A patient is taking ibuprofen, 800 milligrams, 3 times a day by mouth as treatment for osteoarthritis. While taking a health history, the nurse finds out that the patient has a few beers on the weekends. What concern would there be with the interaction of the alcohol and the ibuprofen? So I'll let you look at that and see if you can come up with the answer. If you need to refer back to your Lilly textbook, I'm sure the answer is probably there. Continuing with our nursing implications. We do advise people to take ibuprofen on a full stomach. Do not take it on an empty stomach if you can avoid it, because of the GI irritation and distress that can occur. They are better tolerated if they're taken with food to help with that irritation. As I mentioned, we want to educate people about the various adverse effects of NSAIDs and inform them to notify their prescribers if any of these become severe or if bleeding occurs. And they will be at home self-medicating, except for the Toradol, who will have to be, generally they're in a hospital when they're getting that, and we are assessing for these things on a regular basis. The other piece to anytime you're giving a medication is, of course, always monitor for the therapeutic effects. Are they getting the response that is needed? And this slide talks about the responses are going to vary according to the treatment of the condition being treated, which, if you remember, these NSAIDs are used for a wide variety of things. If we're giving it for a temperature of 101.5, the therapeutic effect would be that their temperature comes down, their fever comes down. In this case, we're in the thinking about inflammation and kind of in the whole relation to pain here. So we want to know that the reason that we give this is that the person experiences an increased sense of mobility, wellness, they're able to carry out activities of daily living, etc. We may even be able to see decrease in swelling or pain, stiffness, and tenderness in a joint. And the final thought here is, remember that ibuprofen is over the counter. That means it has a favorable safety profile in the dosing that is on the label, which is the 200 milligram tablet, take 1 to 2 every 4 to 6 hours. I'm sorry, I think it says 6 to 8 hours. And it doesn't require physician supervision. So people can take this drug at home for their needs. Now, ketorolac, on the other hand, is prescription only. They will be under supervision of healthcare. It's heavily abused in sports, and we're going to cover that when we talk about pain and talk about how that is abused in sports at every level. It's very effective post-operative drug, and it's limited to 5 days, and generally by that 5th day, there's enough healing that's occurred that we can actually move the individual to ibuprofen for their pain control. And we might be able to do it before 5 days as well. But that's how you can look at the two together. That's all we have for ibuprofen and ketorolac in the concept of inflammation.